Okay, welcome once again to Dr. Miller's or Dr. Barbara Miller's NCLEX review. This is the final part of pediatric nursing. You must know not only the diseases of pediatric, but also the growth and development of the child. You'll be asked all that. So let's start with Freud, Sigmund Freud. Okay, you got to know what's the id, ego, and superego. The id is basic sexual energy. The ego is the realistic part, and the superego is the conscience. So if you were to ask who theorizes that, it is Sigmund Freud. The next stages of development: oral to genital. Oral is from birth to 1 year. Pleasure center on the mouth, sucking, biting, chewing. Okay, that's oral. The anal is between 1 and 3 years. Pleasure focus on bowel and bladder elimination, coping with demands for control. The phallic stage is 3 to 6 years. Pleasure zone is the genitals, coping with incestuous sexual feeling. Latency is from 6 to 12 years of age. Dormant sexual feelings, and genital from 12 years to adulthood, maturation of sexual interest. So genital, maturation of sexual interest, latency, dormant sexual feelings. Phallic, pleasure zone in the genitals. Anal, bowel and bladder elimination. And oral, pleasure, mouth sucking and biting. So, introduction to the growth and development. Erik Erikson, each stage of his psychosocial development identifies a crisis or challenge. When needs are met, it's a positive outcome. When needs are not met, it's considered a negative outcome. So what are the stages of development for Erik Erikson? Trust versus mistrust. The baby is crying. You pick that baby up, you fed that baby, the baby will develop a trust in relationship. The moment you start yelling at that baby, the baby will become very mistrusted. So from trust versus mistrust is from birth to 1 year. Autonomy versus shame and doubt, 1 to 3 years. Initiative versus guilt, from 3 to 6 years. Industry versus inferiority, from 6 to 12 years. Identity versus role confusion, from 12 to 18 years. Intimacy versus isolation, 18 to 39 years. Generative versus stagnation, 40 to 65. And integrity versus despair, 65 and above. This is all Erik Erikson. Then another is Jean Piaget, theory of cognitive development. He talks about sensory motor from birth to 2 years. That's object permanence. Object permanence. He talks about pre-operational period from 2 to 7 years. That's magical thinking and animism. Then concrete operation from 7 years to 11 years, conservatism. And formal operation, 11 years and into adulthood, abstract thought. Know that the fontanelles, you have your anterior fontanelles should close at 18 months. Your posterior fontanelles should close at 2 months. Your weight, 6 months, you got to know these things. The weight of the baby doubles at 6 months, and it triples at 12 months. Go over conditions such as REYES, R-E-Y-E-S, REYES syndrome. It is a life-threatening disease characterized by fatty degenerative liver failure and acute non-inflammatory encephalopathy. What's the pathophysiology of REYES syndrome? Hepatic mitochondrial injury causes increase in ammonia levels. What are the risk factors? This associated with recent viral illnesses, varicella, use of aspirin. What are the symptoms of REYES syndrome? Mainly affected the brain and the liver. Vomiting and diarrhea, confusion, seizures, coma, irritability, then death. How do you treat that? You got to support the patient. You want to monitor for increased intracranial pressure. Patient needs to be intubated and placed on the mechanical ventilation. Nursing intervention, you want to elevate the head of the bed. You want to monitor intake and output. You want to give emotional support, prevent hemorrhage, and you want to avoid using of aspirin in children. Let's talk about spina bifida. It's a part of a group defects called neural tube defects. Remember, during pregnancy, the woman will be instructed to take folic acid to decrease the risk factors of neural tube defect, such as a spina bifida. What's the pathophysiology of spina bifida? Incomplete development and closure of the neural tube, leading to spinal cord and nerve vulnerability and damages. What are the risk factors? Folic acid deficiency. That is why it is so important for the nurse to instruct patients who are pregnant or thinking about having a baby to use folic acid to decrease neural tube defect, such as a spina bifida. You do have 3 types of spina bifida. You have spina bifida occulta, the defect of the vertebrae without the protrusion of the meninges or the spinal cord. He may have a tuft of hair or a dimpling and discoloration. Then you have meningeal, the protrusion of the cyst with meninges and the cerebrospinal fluid. The spinal cord not in the sac. Then you have meningeal, is a herniation, protrusion of the spinal cord, the meninges, and the nerve. They're all sitting outside, which places the patient at risk for infection. How do they treat it? Early surgical closure of the defect. Remember now, myelomeningocele, the patient will be wheelchair bound. Patient will have paralysis of the lower extremities. Nursing interventions: cover sac with sterile saline moistness, non-adherence dressing. You want to place the infant in a prone position with hip flex. You want to avoid pressure on the sac. What are the complications of spinal bifida? Hydrocephalus, fluid in the brain, latex allergies, bladder and bowel incontinence, and paralysis. The next condition is cerebral palsy, disorder of movement, coordination, or posture caused by damage to the development brain before childbirth. What's the pathophysiology for cerebral palsy? Abnormal intrauterine development of the brain or a hypoxic brain. Injury damages the cerebral cortex and impairs motor function. They do have different types of cerebral palsy. One, spastic motor cortex damage. This may involve one or both sides of the body. Patient will have stiffness and jerky movements. The limbs usually underdeveloped, muscles, stiffness, and tightness. The second is dyskinetic attitudinal or basic ganglia damage. They call this like worm-like movements, slow riding muscle contractions, drooling, involuntary jerking movements, disappear during sleep and increase with stress. And then the last type of cerebral palsy is ataxic, where the cerebellum is damaged. So that child will have a balance and coordination issues, shaky movement, wide base gait, issue with depth perception. What are the clinical manifestations or signs and symptoms? Muscle weaknesses, developmental delays, tremors, reflex abnormalities, ataxia, spasticity, swallowing, speech, vision, hearing difficulties, intellectual disability, and seizures. The nursing treatment, there is no cure. No cure. But early intervention is paramount. Early intervention increases quality of life. The botulinum toxin, intrathecal baclofen, speech therapy, assistant devices, and orthopedic surgery. What's the nurse intervention? You want to monitor these kids for aspiration, and you want a suction equipment available, or ensure that the suction equipment is available. The next is developmental dysplasia of the hip, the femoral head, and the accipitulum. The ball and socket joint of the hip are improperly formed. The pathophysiology of developmental dysplasia of the hip, abnormal development of the hip joint in the utero, resulting in misalignment of the femur and the acetabulum. What are the symptoms? Asymmetrical inguinal or gluteal skin folds, shortened legs on the affected side, asymmetrical mobility, abnormal gait. You will see that in older children. How do they diagnose developmental dysplasia of the hip? The Barlow, Barlow maneuver, that's an abduction of the hip while holding the knee straight, or the Ortolani maneuver, abduct the hip while the knee flex in a 90-degree angle. How do they treat this? Look at your Pavlik harness for infant less than 6 months old, and surgical reduction with hip, spica cast for children older than 6 months. So the Pavlik harness for children less than 6 months, and the hip spica cast for children older than 6 months. Let's talk about cleft lip and cleft palate. Is another congenital defect causing opening or split in the upper lip, the roof of the mouth, or both. This can have variation of both cleft lip and cleft palate together. The pathophysiology is unknown. Etiology, there's no known cause as to why babies are born with cleft lip or cleft palate. What are the symptoms? Partial cleft lip, partial fissure of the upper lip, complete cleft lip, complete separation of the lip and nasal still, partial cleft palate, separation in the soft palate only, and complete cleft palate, separation in the soft and hard palate. How do they diagnose? Visual examination of oral cavity at birth. Treatment. Cleft lip, gotta remember that, is done first. Cleft lip, the surgical procedure is performed around 3 months after birth, and the cleft palate is performed around 12 months. Nursing, intervention, feeding. Just don't forget that. The lamb's nipple. How do you feed a baby born with a cleft lip, cleft palate? The lamb's, Lambs, nipples, extra long nipples, or wide nipples to help create a seal. For unilateral cleft lip, feed on the unaffected side. Allow adequate swallow time during feeding. You want to feed infants slowly and burp frequently. Post-operatively, apply petroleum jelly to the operative side as directed. You want to utilize the elbow immobilizers to protect the site. Feeding with a syringe or a dropper may be recommended. You want to avoid pacifiers. Sucking can disrupt the suture. Let's talk about hypertrophic pyloric stenosis. What is that? Thickening and narrowing of the pyloric sphincter that connects between the duodenum and the small intestine. The pathophysiology, hypertrophy of the pylorus narrows the canal between the stomach and the duodenum, causing gastric dilation. What are symptoms of hypertrophic pyloric stenosis? Projectile vomiting occurs after eating. Olive-shaped epigastric mass. Remember, olive-shaped epigastric mass, visual peristalsis, dehydration, weight loss. How do they treat that? Pylorotomy, minimally invasive procedure that cuts outer muscle of the pylorus to relieve the obstruction. The next is celiac disease. Celiac is an autoimmune disorder that causes gluten intolerance. Okay, so the pathophysiology of celiac is intestinal intolerance to dietary gluten that causes damage to the villi in the small intestine, leading to malabsorption. What are the symptoms of celiac? Abdominal pain, septorrhea, abdominal distension, diarrhea, weight loss, anemia, failure to thrive. Remember, the treatment for celiac is a gluten-free diet, meaning no barley, no rye, no oats or wheat. Let's talk about another condition that you will see at birth: intussusception. Intussusception is a segment of the colon that telescopes into another portion, causes bowel obstruction. If the baby is not able to have a bowel movement, so the pathophysiology of intussusception is the proximal segment of the bowel telescopes into the distal segment, resulting in obstruction, which causes ischemia. Most commonly happen with the ileum into the cecum. What are the symptoms? Red currant jelly. You put a little check there. The child will have a sausage-shaped mass in the upper abdomen, vomiting, fever, abdominal pain. How do they treat? It is diagnosed and treated with a barium enema or surgical reduction. Nursing intervention of IV fluids, nasogastric tube for decompression, for gastric decompression. Child must be NPO, and you want to monitor the stool. The next one is called a Hirschsprung disease. Birth defect with missing ganglion cells in the segment of the colon. What's the pathophysiology of Hirschsprung disease? It's a congenital disorder causing lack or absence of the ganglion cells in the colon, which leads to decrease in bowel motility. What's the signs and symptoms? Failure to pass meconium. So you got to observe the child not able to pass meconium during the first 48 hours. What is meconium? Is the first stool. So meconium is going to be dark and tarry. Okay? So what are the clinical manifestations? Failure to pass meconium within the first 48 hours of life, ribbon-like stool, abdominal distension, vomiting bile, failure to thrive, palpable fecal mass. How do you treat? Surgical removal of the aganglionic portion of the bowel with a colostomy. The next condition that you may encounter questions on is the Duchenne's muscular dystrophy. Remember, this is a genetic disorder that progressively damages and weakening the muscles over time. What's the pathophysiology? It's an X-linked recessive genetic disorder that causes progressive weakness and atrophy of the skeletal and heart muscles. What are the symptoms for Duchenne's muscular dystrophy? The Gower's sign. What is the Gower's sign? Gowers is hand on thighs to push to stand. Hands on the thighs to push to stand. Cardiomyopathy, the waddling gait. Waddling, W-A-D-D-I-N-G, waddling gait. Calf enlargement, delay motor movement and speech, cognitive impairment. So how do you treat Duchenne's, for lack of a better pronunciation, treatment? There's no cure. Okay, so how do you treat this? Glucocorticoids to delay cellular damage, AVE inhibitors and beta blockers for cardiomyopathies. Palliative care, death usually occurs in the 20s due to cardiomyopathy and respiratory muscle weakness. Nursing intervention encourage ambulation as long as possible. Healthy diet to avoid weight gain. Let's talk about phenylketonuria, or I just batched that, phenylketonuria, or PKU, sorry for lack of a better pronunciation. It's a rare genetic disorder of the inability to break down phenylalanine into tyrosine that can lead to brain nerve damage if untreated. So the pathophysiology of PKU, remember, PKU is done maybe on right before the patient goes home, okay, to determine if the baby has allergies to protein. Okay, so the pathophysiology, phenylalanine is an essential amino acid in the body that converts into tyrosine through PKU hydroxylase. So tyrosine converts into other products like dopamine, serotonin, norepinephrine, epinephrine. In PKU, there is decreased phenylalanine hydroxylase, which impairs the ability to use phenylalanine, which leads to buildup of phenylalanine in the tissue and blood. So what are the signs and symptoms? Fair hair and skin, eczema, musty body odor, neurological dysfunction. Treatment is SAP protein to decrease the phenylalanine, and regular blood test is paramount. Nursing intervention, diet, phenylalanine-free formula like protein without phenylalanine, limit protein intake, amino and supplementation, and avoid aspartame, that's artificial sweetening. PKU, they may ask you what type of test. Is the Gertrude, G-U-T-H-R-I-E, is the name of the blood test that is done to determine PKU. Okay, so this is the end of pediatric nursing. I hope this review helps you to gain more knowledge on pediatric nursing to be able to succeed on your NCLEX test, whether it's a PN or an RN examination. Please like, share, subscribe, and comment on each video. Thank you so much. I will see you again in the next video.